Hi, everyone. I'm Dr. Nasir Gami. Thank you for joining me for today's live stream. Sorry for the delay in getting started. I hope you see and hear me okay. And we're going to have some links added at the end of this presentation based on the discussion regarding adult ADD and child ADD. So the discussion today is about attention deficit disorder. I'll begin by making the point that I refer to it as ADD, not ADHD. I dropped the H for hyperactivity because there's no proven studies that show that hyperactivity is part of a clinical syndrome that people want to call ADHD that is different from other clinical conditions where hyperactivity occurs, such as mania or bipolar illness. If there are such studies, feel free to send me a link so we can discuss it. But as far I have not seen such studies, and therefore the idea that hyperactivity is a core and legitimate central feature of the so-called ADHD syndrome has never been proven and is a major cause for misdiagnosis of it. The core of the idea has always been inattention and executive dysfunction. So let's discuss that. The first thing we're going to discuss is whether this is a valid concept, whether there's scientific validity to the concept of inattention, executive dysfunction, defined in such a way that there's a clinical syndrome that people are calling ADD, either in children or in adults. Let me get into that, and I'll just mention one thing that some folks are saying the link is not working in the live video, and perhaps we can get colleagues to help me with that, but I'll move ahead. So let's discuss the concept of validity first. What do we mean by validity? Validity means that something is real, that it really exists. You can define something, but that doesn't mean it's real or it exists. So for instance, I can give you a good definition for the idea of a unicorn, but unicorns don't really exist. We might be able to define it so well that we all agree on how to define the term unicorn. And in psychiatry, we call that reliability, that there's agreement between clinicians. But just because we agree on how to define something doesn't mean that it really exists. What do we mean by exists? It exists out in the real world, in the world of biology, in the world of nature, in the world of psychological reality. And we don't know that that exists until we have a definition of validity, and that can be applied to these clinical definitions. So, for instance, in medicine, one of the things that is used is pathology or autopsy or laboratory tests. These are ways that we validate clinical signs and symptoms. It's not enough to say that you have this symptom or that symptom, but that you can validate it means that those signs and symptoms reflect a separate disease or illness than other diseases or illness. Sometimes you have the same signs or symptoms in different diseases. Fever can occur in many different diseases. Sometimes you have different signs and symptoms in the same disease. You can have HIV, for instance, or lupus with a whole range of symptoms. So the mere presence of symptoms or signs and the differences between symptoms and other conditions with other symptoms doesn't mean they're different diseases. You have to look at something beyond symptoms. And in medicine, we look at pathology and laboratory tests. Well, in psychiatry, we don't have pathology and laboratory tests. So what do we do? Ever since 1970, a classic paper on this issue, it has generally been accepted that we should look at independent lines of evidence separate from symptoms that go along with the symptoms to define syndromes that we think are different diagnoses and may in fact reflect different diseases or illnesses. So what are those different lines of evidence? There's at least four. The first one is the symptoms, but by symptoms we mean symptom specificity, that symptoms differ between different syndromes. As I said, that's not definitive, but sometimes that's useful. The second is genetics or family history. That's relevant if you have a genetic disease. If you don't have a genetic disease, it's not so relevant. Bipolar illness and schizophrenia, autism are genetic diseases. Family history is relevant. Anxiety and personality and PTSD are not genetic, and therefore the family history is irrelevant. The third line of evidence is the course of illness, age of onset, whether it's episodic or constant or chronic, outcome, whether there's recovery and remission or not, naturally, by the natural course. The course of illness is relevant for all diseases. And the fourth line of evidence is biological markers, which we usually don't have. Occasionally we do. And as a proxy for biological markers, treatment effects, which sometimes is useful and sometimes is not, because treatment response and treatment effects can be non-specific often. So if we apply these four validators to ADD, what do we see? Symptom specificity, family history or genetics, course of illness, and biological markers or treatment effects. Let's start with symptom specificity. The core of ADD, as we said, involves inattention and executive dysfunction. Inattention or distractibility, is that specific to so-called ADD? No, it happens a lot in anxiety conditions, happens a lot in mood conditions like depression and mania, happens in psychosis. It can happen in other cognitive syndromes. So it's not at all specific to ADD. Just because you have inattention and distractibility, it doesn't mean that you have ADD. That's a very common mistake, especially among people who are looking things up on the internet. So I'm seeing that there's a problem with my screen not showing up. Okay, I'm going to take a pause here and see if I can show my screen. Let me see. As far as I can tell, I'm in the screen, but I'll do it again. I'm going to stop the screen and restart the screen. Okay, so I'm back on the screen. I'm going to ask my friend Elio to let me know if he can see me. And if he does, then we can continue.
I am seeing just you again. I'm seeing you 2 times.
You see me 2 times.
Yeah, I think it's best if you just share the slide presentation.
I don't have any slides. How do I look now?
So you can go on with just your image. Is that okay?
All right. Do you see me on the screen fine?
Yeah.
Okay, well, then we'll proceed with this. So, yeah, I could have shown slides, but I wasn't prepared for that. So I'm just going to speak to it now. Maybe we'll do another lecture where I can show some slides. So anyway, let's start with symptom and symptom specificity. When you look at certain studies that have looked at ADD in adults and children, what you find is that in 80% or so of adults and in about 60% of children, whenever ADD is diagnosed, they also are diagnosable with mood conditions, depressive illness or bipolar illness. And so you might claim, well, it's a terrible thing. Every time you have ADD, you have a second disease, a mood disease. Generally speaking, nature, and if you believe in God, nature is God, doesn't tend to give people 2 diseases at a time. It usually gives them 1 at a time. And the more common thing is that a disease may have multiple symptoms. So every time you have pneumonia, you're not so unlucky that you also have a fever disease in addition to pneumonia. Pneumonia causes fever as a symptom. It's not a fever disease. When you get pneumonia, you don't also get a cough disease. Pneumonia causes cough as a symptom. It's not a cough disease. When you get pneumonia, you don't get night sweat disease. Night sweat is a symptom of pneumonia. If we were to call every symptom a disease or a quote unquote disorder, we would have multiple names for what really is only one thing. In psychiatry, this leads to the false comorbidity problem of DSM, where people are diagnosed with ADD and they say, oh, they're also depressed, so they have MDD, and they're also anxious, so they have GAD, and they also have insomnia, so they have a sleep disorder. All that's ridiculous. We really need to say, is there one disease or one diagnosis that captures all these symptoms before we say there's something else? And in medicine, this is generally called a hierarchy of diagnosis. And when you go to medical school and you start learning about diagnosis, everyone learns that when a patient presents with some certain symptoms, you create a differential diagnosis. You start with one diagnosis that would explain everything, or as much of everything as possible, and then you rule it out before you go to other diagnoses. One way of doing this is, of course, by knowing the cause. And many people in psychiatry say, oh, we can't do this because we don't know the causes or the etiologies. That's actually irrelevant. We don't know the cause of diabetes, asthma, hypertension, migraine. But we can still make those diagnoses in medicine and apply the concept of a differential diagnosis. You don't need to know the cause to take a hierarchy approach. contrary to the beliefs of some of the DSM proponents. Instead, one approach is to say, what's the diagnosis that is polysymptomatic? It has many, many different symptoms. Rule that out before you go to smaller and smaller diagnoses that have fewer symptoms. So for instance, HIV, lupus, as I mentioned, are conditions that have many, many different symptoms. You want to rule them out before you say someone has the common cold, for instance, which has fewer symptoms. Similarly, when someone has inattention, distractibility, and executive dysfunction, you want to look at anxiety and mood conditions and rule them out before you say they have just a disease of inattention and executive dysfunction, so-called ADD. So among the mood conditions, what do you rule out? Obviously bipolar illness and unipolar depression, so-called major depressive disorder. And then anxiety conditions, you have obsessive compulsive disease, things like that. People will refer to generalized anxiety. That's actually not a valid concept either. We can have a further discussion about that. But anxiety often flows out of diseases like depression and bipolar illness. When you're depressed, when you're manic, people often are very anxious. When they're not depressed or manic, they're not anxious. Similarly, there are psychotic diseases like schizophrenia, schizoaffective illness that obviously cause both mood symptoms and anxiety, and therefore can cause executive dysfunction and cognitive impairment. So you want to rule out mood illness first, then psychotic diseases, then anxiety states if you've already ruled out the mood. That could be, for instance, post-traumatic stress disease or OCD. You want to rule all that out before you say someone might have ADD. Well, when 60 to 80% of people have mood diseases, they don't have ADD, is what I'm saying. Now, you might claim they have the mood problems because of the ADD. For instance, they're depressed because they can't focus or concentrate. You can claim that. It's never been proven. Show me a study. Show me a study that shows that patients with ADD have depression because of the ADD and not because they have a depressive illness to begin with. In fact, there's no such research, again, that I'm aware of. There's 100 years of research that shows that mood illnesses, long before the concept of ADD ever existed, that mood illnesses cause impaired concentration and cognitive impairment. And there's increasing evidence of that. And there's zero evidence ever, whether in the past or in the present, that ADD causes mania. No one claims that even, I don't think. So if you have 40% of adults with ADD having the comorbidity of bipolar illness, as shown in the national surveys, it doesn't make any sense to claim that the ADD is simply there despite the fact that they're bipolar or it's causing the bipolar, because there's no logical rationale for that. On the other hand, we do know that bipolar illness simply classically causes cognitive impairment, executive dysfunction, and inattention. So mood illness could explain 60 to 80% of the reported supposed cases of ADD. And then what's left over, psychotic illnesses can cause some of them, and anxiety conditions can explain the rest. In other words, I'm not sure that when you look at symptom specificity, there's any clear evidence that there's anything left over that you could claim is just a condition of inattention, distractibility, and executive dysfunction once you've ruled out mood illnesses, psychotic diseases, and anxiety conditions. So that's symptom specificity. The second claim is around genetics or family history. Now, you might say, well, there's all this genetic research about ADD running in families. There's genome-wide association scans showing it. But what's interesting about those is they don't show it's just ADD. Similar to the symptom specificity issue, there's no genetic specificity. Those same patients have massive overlap with so-called MDD, major depressive disorder, depression, mood illnesses, bipolar illness, and anxiety states. So there's no genetic specificity for ADD. Therefore, it doesn't support the concept that it's specifically different. Let me take one question that's coming up on the stream. What about ADHD proponents who explain episodes of so-called hyperfocus? I've heard that too. That's like the hyperactivity. Show me one study where there's hyperfocus, quote unquote, in ADD, in a syndrome of patients that they claim have ADD, that differentiates it from other clinical syndromes like bipolar illness or other states. When people are manic, they often do focus quite excessively, quite well. They can actually be very productive and creative. Show me that those patients do not have mania. There are zero studies that show that. Again, it's ADHD proponents. They think only one way. They don't think outside their box. And therefore, they come up with these false concepts that they've never proven to be valid. Let me move on. Then I've talked about symptom specificity and genetics. Now we move on to course of illness. So here's the strongest evidence against ADD, course of illness, especially adult ADD. Because the concept of adult ADD is that people will have the condition when they're children, and then it persists when they're adults. Now, if you look at the literature before about 2000, when the first medication came out for so-called adult ADD, atomoxetine or Strattera, there's good reviews that show over 10 studies prospectively that about 90% of patients no longer had ADD after progressing from childhood to adulthood, meaning they had diagnosed with it before age 18, but they were not diagnosed with it at about age 18 or above. These are prospective studies with hundreds and hundreds of patients. Now, in the 2000s, after the first FDA approval for adult ADD came out, and especially after DSM-5 in 2013 made adult ADD part of the official diagnostic system, after that time, many people have been diagnosing ADD in adults and routinely doing so, actually, in children who grow into young adulthood and later. There are some studies where people report high prevalences as much as 60% in adulthood, as opposed to 10% in those earlier studies. Well, the 60% studies are retrospective. The 10% studies are prospective. The prospective studies are more valid than the retrospective studies. There's no prospective study that's ever shown 60% prevalence of ADD into adulthood. In fact, there are newer prospective studies that continue to show a low rate of about 20% or less prevalence of ADD persisting into adulthood. And there's a lot of interesting features to those new prospective studies. There's two of them in the last decade that I'll highlight. One of them followed kids prospectively from age 12 to about age 19. The other one followed 8-year-olds to age 41, 33 years prospective follow-up. A couple hundred people, ADD group, control group. So when they're 8 years old, they're defined as having ADD, they have it, and they're defined as not having ADD, they don't have it. It's not about clinicians not diagnosing it or missing it. The researchers are actually assessing the children, and they either have or don't have ADD. They then spend 33 years following them up prospectively. Now, that's an awful hard thing to do, and that's a lot of hard research. By age 41, 80% of those children no longer had ADD. That went away. A number of them had anxiety states, mood conditions, psychotic conditions, personality disorders, as we discussed, other conditions that can impair your cognition. Now, what's interesting is that about 10% of the population has been diagnosed with ADD, tends to be diagnosed with ADD in childhood. About 5% in adulthood is the general prevalence rate. So you would think maybe 50% persist. But these prospective studies show those are not the same people. In the prospective studies, again, 5% of patients in adulthood met diagnostic criteria for ADD. But the interesting thing is that 80% of them did not have it when they were children. Remember, these are prospective studies. So they were studied at age 8, at age 11, and then followed prospectively to age 19 or age 41. And they had a control group that did not have ADD, followed prospectively to age 19 or 41. 80% of the people in adulthood at age 19 or 41 who met ADD criteria did not have it when they were children, and they had been looked at when they were 8 and 11. So that means they don't have adult ADD, because adult ADD by definition means the persistence of childhood ADD. But the children who had ADD didn't persist, 80% of them, and the adults who met ADD criteria didn't have it when they were kids, 80% of them. So they don't have ADD. So what do they have? Anxiety states, mood conditions, psychotic conditions, these other conditions that can cause inattention and cognitive impairment. So the prospective trials disprove the idea of the validity of adult ADD, because the vast majority of patients actually don't have childhood ADD that persists into adulthood. Well, you might say, what about childhood ADD? Do they disprove the validity of childhood ADD? Well, again, 90% of children don't persist 80 to 90% into adulthood. So they might have it in childhood. That doesn't disprove the idea that some children do have inattention and executive dysfunction that is not attributable to mood and anxiety states, but it goes away. It's temporary. It's a developmental delay. It's not a disease that stays with you forever. And actually, there's a very nice NIMH study looking at children from age about 8 to age 12, 13, 15, and they did prospective MRI scans. And they showed that the children with ADD, compared to normal controls, had some abnormalities in their MRI showing developmental delay of maturation of the cortex, especially in the frontal lobes, but other parts of the brain. And this all normalized by age 12 or 13. So it was abnormal at 8, it was normal at 12 or 13. That's the period where the ADD can be diagnosed, but then it goes away. It's not normal, but it's a developmental delay. It's not a disease. It doesn't persist. So that's, I think, how I would look at the course of illness. So what about the fourth validator, biological markers and treatment effects? There are no biological markers specific to ADD, separate from anxiety, depression, mania, bipolar illness, and psychotic states. There's overlap in a range of biological markers, nothing that's been proven specific. What about treatment effects? People say, oh, all my patients got better on amphetamines. Their focus is a lot better, therefore they have ADD. Well, my focus would be better too. I'd give you a much better lecture right now if I just took some Ritalin before this lecture. Your focus would be a lot better too. Anybody's focus is better if they take amphetamines. That's one reason why they're highly abused, and they are highly abused. About 20% of college students use amphetamine. Only about a third of them are actually prescribed. The other ones share them with each other or buy it on the street. Clearly an abused substance. That's why it's a controlled substance legitimately. Before it became controlled in the 1970s, it was widely abused in the American population and in other countries. That's why it became controlled. So it affects the normal population. There are many studies that show that amphetamines cause improvement in cognition separate from whether you have an ADD diagnosis. They do it if you have a schizophrenia diagnosis. They do it if you have no diagnosis, normal controls. So improvement of attention and executive function with amphetamines is not at all any kind of validation that ADD is a legitimate disease, because it's a non-specific thing. Everybody's anxiety improves when you give them Valium or Xanax or Ativan. That doesn't mean we all have anxiety diseases, because anxiety is a normal cognitive and emotional trait. It's like height and weight. It's on a normal curve. Some of us have a lot of anxiety, some of us have less. And if you take a benzodiazepine, it reduces us all a little bit on that anxiety curve. Similarly, inattention is a normal cognitive trait. It is not normal to focus on everything all the time. If you focus a lot, you have obsessive compulsive disease, which, by the way, amphetamines cause. Or you have psychosis, which, by the way, amphetamines cause. It's normal to have selective inattention. There's a normal curve. Way too much, you have obsessiveness and delusions. Way too little, you get mislabeled ADD. In the middle, we have selective inattention, which is the way you're watching my video right now. You're not paying attention to everything I say or do. You're not paying attention to all these little books back here and every little aspect of this, and you shouldn't, because you can't understand what's going on if you don't selectively focus on some things and not focus on other things. And that's normal. But we are labeling that as abnormal when we want to get an A instead of a B. We want to get promoted to this job instead of that. And that's a lot of the misuse of amphetamines for so-called ADD. So some people would say, okay, Dr. Gami, you're arguing with me about the validity of ADD, but all what you just said is true. I study better. I get better grades. I function better. Why shouldn't I just take something to function better? One of our psychiatric colleagues on former Twitter has made that comment recently. Someone brought to my attention. I know others of my colleagues I've talked to in our department at Tufts Medical Center practice that way. And my answer to them is, well, why don't we all give testosterone to everybody so that they have higher sexual function and stronger muscles? Why don't we give steroids to everybody so that we all have more energy and we can be more athletic and be exercising more? And of course, athletes do famously abuse steroids. Why do organized bodies of athletics ban steroids? Partly because it's unfair to the people who don't take steroids. Partly because depending on how much you take, it gives you a competitive advantage. And also because we know that steroids are harmful medically. They cause mania, aggression, psychosis. There are cases of homicide, suicide. Nothing happens for free in nature. If you take some substance that makes you feel better at something, it's going to harm you in some other way. And we can talk about this more in another discussion, but amphetamines are neurotoxic and cardiotoxic. They kill neurons, and that's been well proven in animal studies over and over again. We'll put a link to this podcast where we have a review paper where we listed all these references. You can read them up for yourself. It's very well known to neuroscientists that amphetamines, including methylphenidate, which is an amphetamine, again, described in our paper, methylphenidate and dextroamphetamine, your two main pharmacological amphetamines, are neurotoxic. They kill neurons. They do so in young animals more than older animals, so maybe even more of an issue if we give them to children. It's never been disproven in humans. It's never been shown that they're safe in humans. There are very few human studies, mostly because we ignore the issue. Clinicians and researchers pretend there's no issue here. They don't even know about it usually. I've talked to a colleague who's one of the world's experts on ADD, and he told me he'd never heard about this, even though it's very commonly known among neuroscientists, PhD researchers on the brain, that amphetamines are neurotoxic. For some reason, psychiatrists, clinicians don't know this. You should know this, and you should tell your patients. Now, you might say, well, it hasn't been proven in humans, but you should tell your patients then. Here's a drug that's toxic to neurons in all animal species studied, from mice to monkeys, and we don't know what it does in humans. Go ahead and take it. Take it if you want it, and see what your patients say. Let your patients decide. Maybe they want to take it, but at least they should make the decision with a little knowledge. The second point is it's cardiotoxic. Now, this has been studied more. It seems to be less harmful in children than in adults. Now that amphetamines are widely used in adults, we are getting some large samples of observational studies, which have to take with a caveat. These are not randomized trials, and it's hard to assess these kinds of relatively infrequent but serious risks in randomized trials, because you have to treat a lot of people to do it. And of course, that's hard to do, requires a lot of funding. These days, nothing's getting funded. But so you look at observational studies, and that's legitimate with some controls. And there are some observational studies in large samples that show that amphetamines double the risk of sudden cardiac death in middle-aged adults. Not so much in children, but in middle-aged adults. Increased risk of sudden cardiac death. Cardiac arrhythmias are well known to be caused by amphetamines. It seems to translate. Now, a colleague of mine who highly supports amphetamines says, oh, but that's infrequent. Okay, it's infrequent. So tell your patients you have a twofold higher rate of sudden cardiac death, but it's not very frequent, and see if they want to take the medication. At the very least, we should inform our patients about these risks and harms, and not assume that they don't matter and not tell them about it. And that's the way I think I would address this issue regarding some of the risks of amphetamines. So if you claim amphetamines are helpful, yes, they are. They improve attention and cognition in a general sense, but they also have these harms. And you have to ask yourself, do those benefits outweigh those harms, especially with long-term treatment? You might argue for short-term treatment in children, briefly during school years, not in the summer. We can talk about that. But the idea you can just get on these, stay on these for decades and decades and don't worry about it is, I think, not very supportable scientifically. And I think ethically, I would have a problem with that as well. I know my other colleagues would be maybe not as happy with me on that notion, but let's have a discussion about it. The way it is now, people are just ignoring this issue. There are non-amphetamine treatments you could give for attention. For instance, bupropion is got an amphetamine-like structure, but it's much less potent. There's no proven, at least, the risks of neurotoxicity and even cardiotoxicity with it. At low doses, it might be a lot safer. You have these non-amphetamine alternative stimulants, for instance, like Provigil and atomoxetine Strattera, that one might consider instead of full-on methylphenidate and dextroamphetamine and all of its variations that are getting so highly marketed. By the way, in terms of function, you could also add that there is not good evidence that these amphetamines give you better function than non-pharmacological interventions, such as behavioral therapy, and even other interventions like parent interventions. There are decent studies that interventions with parents improve the function of children diagnosed with ADD. ADD coaching is an option. Behavioral therapy has been very well studied in the multimodal treatment of ADD study, the MTA study, the longest study of ADD. That's a randomized trial about a year long. And methylphenidate primarily and other amphetamines were not statistically or clinically significantly better than behavioral therapy alone without medication for functional outcomes in children with ADD, meaning parent relationships, social skills, and teacher relationships. as well as academic functioning. The behavioral therapy was just as good. The medication was better for subjective symptoms of inattention and disorganization, but not better when you looked at functional outcomes. So the claim that we have to use these medications for functional outcome as opposed to non-pharmacological approaches is not supported by the current available evidence. So that would be my summary of the issue around the validity of ADD, and some discussion about treatment as reflects to the question of just treating the symptoms or the function. And I'm sure this will generate questions and opposition and maybe some support, and we can continue to have this discussion in future episodes. But thank you for joining me today. If there's any further comments, you can put them up on this website now for the live stream, and I'll answer it. And I will put up links, as I said, to describe some of what we're referring to. There's a review paper that we published some years ago that covers a lot of this. And I should mention one more thing, actually, before we stop. Another aspect of the mood illness leading to ADD that's often underappreciated, and people will often say, well, it's not a mood illness because the inattention and executive function is there all the time, but mood illnesses are episodic, they come and go. And that's true if you have full-blown severe unipolar depression and bipolar illness with mood episodes of depression and mania, and the inattention and executive dysfunction is worse during the episode, but better in between the episodes. But what people fail to appreciate is that in between the mood episodes, people are not well a lot of the time. We did a study once showing that about half of the patients with mood illnesses have mood temperaments in between their mood episodes. That means they're either dysthymic, always down a little, hyperthymic, always manic a little, which is not in DSM, or cyclothymic, up and down all the time. And of course, if you're cyclothymic or hyperthymic or even dysthymic, down or up all the time, you're having depressive symptoms or manic symptoms mildly all the time, you often have inattention, poor concentration, executive dysfunction, often anxiety, which also worsens the executive dysfunction. So it doesn't have to be episodic. And we published a study recently, about a year or two ago, which reviewed our clinical experience at Tufts Medical Center in our patients in our mood clinic who came to us with prior histories of treatment with amphetamines and or diagnosis of adult ADD. We gave them a temperament scale, the TEMP scale, which we'll talk about more, which helps assess these mood temperaments. And we assessed it clinically as well. And we found that about 2/3 of the patients who had received amphetamines or been diagnosed with adult ADD actually had mood temperaments, most commonly cyclothymia. They actually did not get better in the majority of cases with amphetamines for their ADD. And the reason for that is, if you have manic depressive illness, whether bipolar or some variety of unipolar depression, amphetamines can help the depressive symptoms, but they can cause and worsen manic symptoms or cause mixed states, and then that worsens the inattention, executive dysfunction. Amphetamines cause anxiety, and that worsens the inattention, executive dysfunction. It causes insomnia that can destabilize the mood illness. So the mood symptoms got worse in these patients on amphetamines, and the cognition symptoms didn't get better in the majority. Whereas in people without amphetamine treatment, they didn't have cognitive symptoms as much, but their mood symptoms, of course, got better with non-amphetamine treatments and mood stabilizers. In our clinical experience, when patients have cyclothymia and mood temperaments, like dysthymia, but mainly cyclothymia and hyperthymia, we give them low-dose mood stabilizers like lithium 300 to 600 milligrams a day, or Depakote 500 milligrams a day, and their mood temperament gets a little better, but what really improves is the effects of the mood symptoms, namely their anxiety and their inattention, executive function gets a lot better. Just to give you a final example as a case example, one of my patients is a woman in her late 50s. She'd been diagnosed with generalized anxiety disorder, major depressive disorder, and attention deficit disorder for 20 years, had been treated with at least half a dozen SRIs and multiple amphetamines, did not get better. We diagnosed cyclothymia after the historical assessment and the TEMPS scale, and treated her with lithium 300 milligrams. And within a few months, she had marked improvement in her inattention, executive function, and anxiety, as well as depressive symptoms. And at a year of follow-up, she reported massive improvement for her depression, total ability to concentrate, much improved function. After decades, essentially, of failure of SRIs and amphetamines, she responded to low-dose lithium because we got at the cause and not the effects. The cause is the mood temperament. The effects is the inattention, the anxiety, the executive dysfunction. So my rule of thumb is if someone's diagnosed with MDD plus GAD plus ADD, they really have something like cyclothymine. So I'll leave you with that final thought, and I look forward to further discussions on this topic with you in future episodes. Thank you.